Hi, everybody. Welcome back. It is Dr. Rebecca Griffith, the Emergency Department DPT, and I am so excited to have you for another episode of the Admitted or Not podcast. And I have with me today Dr. Howard Kim. Welcome.
Hey, thanks for having me.
Go ahead and introduce yourself and tell us a little bit about your role in emergency medicine.
Sure, I'm an emergency physician and health services researcher. I work at Northwestern University in Chicago, but I trained and did residency in Denver, Colorado, but I don't think we ever crossed paths there.
No, but you're still well
Two
known.
ships,
Yeah.
like two ships passing in the night is what I was about to say. Um, so after graduating residency in Denver, I came to Northwestern to do a research fellowship and have stayed here since then. I think I've been here 7 years now. Originally my research focus was on, looking at appropriate opioid prescribing, and eventually sort of evolved into a better way to manage acute and chronic pain, which is how I started doing research on ED physical therapy as sort of a health services innovation to improve patient and hospital outcomes.
So one thing I've noticed with emergency physicians is that a lot of them just really aren't familiar with what physical therapists do. So how did you get to the point where you not only embrace having PTs working with you, but are willing to do research to support what we do?
Yeah, I think Northwestern had a ED physical therapy like pilot program, I guess, when I got here, and so I was just fortunate enough to work at a place that had an ED physical therapist who would be primarily based on a consultative model, but was dedicated to the ED and was around and there all the time, seeing patients with back pain or vertigo or older adults for fall safety assessments, et cetera. So I had the benefit of working at a place that had an EDPT model, which not a lot of places had back in 2015, 2016. And I really just saw firsthand how much of an improvement it made in the patients and how much the clinicians really appreciated having the physical therapist around, which really led to my interest in studying the effects of ED physical therapy on different clinical areas.
So what clinical areas do you particularly focus your research on? Where do you think we have the biggest bang for our buck?
So I have two active trials right now. One is looking at the area of low back pain, which for us at least is probably the number one reason that physical therapists get involved with ED patients. And then the second is vertigo dizziness, so vestibular therapy, which may be probably tied for second most common reason that we have ED physical therapists evaluate our patient. I think the third would probably be geriatric assessments, tied with vertigo dizziness assessments, and oftentimes in the same patient population. But one of my colleagues, Scott Dresden, has a trial looking at sort of a bundled care intervention for geriatric patients, which involves the physical therapist and a pharmacist and a social worker and a specialized geriatric nurse. So I don't have any active research in the geriatrics area because my colleague Scott Dresden does.
Yeah, one of our physicians, Dr. Goldberg, is also looking at that with her gap care model. So we're actually going to be helping complete some of that research here in January, so we can help her finish her trials to look at pharmacists, physical therapists, case management, and helping our older adults thrive a little bit better. And as you may or may not know, Medicare research actually shows that if a patient was evaluated by a physical therapist in the emergency department, that their overall cost is lower. Also, their bounce back rate is lower. So I'm interested to see where this research is going. But what have you found in your research on low back pain?
Yeah, our clinical trial right now is ongoing. So this is a randomized trial that was based on our pilot work that we performed a couple of years ago. But the pilot work basically looked at patients with low back pain who were either seen by a physical therapist or not seen by a physical therapist, aka usual care. We looked at a number of outcomes, including care variables reflecting the type of care they received in the ED, and then also patient-reported outcomes, so patient functioning, pain, medication usage over the 3 months following their index ED visit. Basically found that patients who were evaluated by a physical therapist had greater improvements in functioning, less disability, and lower usage of potentially high-risk medications like opioids and benzodiazepines. The limitation of that pilot work was that it wasn't randomized, which means that there could have been key differences in the types of patients that got referred to physical therapy and those that didn't, that could explain some of those differences. So that's the motivation for doing our current randomized trial, which will be a much more, I think, complete and scientific assessment of the effects of physical therapy and low back pain.
And in your study, have you really like standardized the care that the physical therapists are providing, or is the physical therapist just responsible for making those care decisions?
Yeah, that was another big reason to conduct this additional study. I think in the pilot study, there hadn't been a lot published about the ED physical therapy care model, and we didn't have a lot of funding for that pilot study. So I think for that prior study, a lot of it was just sort of there's this big black box of what the physical therapist does, and we send them in there, and then we're studying the effect of that, but we don't quite know what the components of the intervention are. At
Yeah.
least the reader of the article doesn't. Obviously, the physical therapist does. So for this randomized trial, which has substantial amount of grant funding and is being conducted in a much more rigorous fashion, we had to protocolize or define the components of the intervention. So basically, we modified some prior clinical care algorithms for low back pain, adapted them to the emergency department setting and sort of our unique practice styles of our ED physical therapist, and then formally put it to pen to paper, protocolized it, and so everybody gets the same type of intervention. And then we record sort of how each patient follows our clinical care pathway. So whether they're like a directional preference or traction, stabilization, basically treatment-based classifications. It's a
Yeah.
modification of that.
That's great, because I think every physical therapist who's listening right now is probably like, a physician decided how we would treat low back pain. And that's not the case. We interviewed Kyle Strickland just recently, who is the PT who's primarily involved in your research, correct?
Correct. Yeah. So basically, it's Kyle's protocol. We also worked with Amy Seitz, who's a PT and PhD here at Northwestern, and she teaches the low back pain curriculum to the PT students here. So just to reassure you, I had zero input into the actual creating the components of the protocol, but more so putting it to paper and operationalizing it.
That's amazing. So as a physical therapist who treats patients with low back pain in the emergency department, one of the things that I notice is that no two patients are the same, and some patients are screaming and can't get off their stomach. Other patients are like only comfortable standing and they can't actually sit down. Like it's very hard for me to standardize the assessment, let alone the intervention. So I'm wondering, like, what are your exclusion criteria, or like, how are you standardizing the patients from that perspective?
Yeah, so the exclusion criteria for enrollment into the trial are particular, and I would say those specific behaviors wouldn't necessarily make someone go in or out of the study. But we do have some exclusion criteria for patients that have multiple problems going on. So if a patient comes in and says, I have a headache and my shoulder hurts and my back hurts, and also, I've had a cough, then that's not a patient that would be included in the study because there's just too much going on. And when we collect the assessments and assess their amount of disability or pain, all those other things would be contributing to their global report of pain and functioning and stuff like that. So we exclude those patients. And then there's also a question that the research assistant asks the treating physician, like, do you think this patient has isolated low back pain? So a patient that may come in with other reasons for ED visit might fail that criteria. But then in terms of sort of some of the unique patients we see in the ED and, sort of ranging the whole, scale of human emotion and human behavior, I think that's the tough part of working in the ED. That's the tough part of having any patient or consumer oriented role in any job really in society. It's that people don't really follow a textbook stereotype or archetype. It's just that people behave in different ways, and that maybe a reflection of pain is a very subjective experience, and people demonstrate their pain in different ways, and that's sort of some of the challenge of working in our clinical environment too.
I totally agree with you. I'm in a fellowship program right now for orthopedic manual physical therapy, and every article I read, I'm like, this is not my patient. Like, these are a lot of the research will come out of, like, say, the military model, and we're looking at young men ages 20 to 40 and who are fit and healthy at baseline, who have really good support, really good follow-up, excellent access to care. And then I think, how do I apply that to my 65-year-old unhoused patient with a substance abuse issue who has nowhere to go, no access to care, maybe no health insurance, no ability to manage their other comorbidities? it's very difficult to like apply the research to that patient population. So I actually really appreciate that you're trying to do that so that we can see how we can best help our very unique patient population.
Yeah, and the way that the clinical pathway works is the physical therapist basically attempts some different treatments, assesses their response, and if they get to the very end and we can't place them into any of the bins for a treatment-based classification that we've adapted, they kind of go into this miscellaneous bin, in which there's a lot of other psychosocial factors contributing to a patient's pain experience. And one of the reasons that for all patients, we really try to provide counseling on pain management, education on expected symptom trajectory. So a lot of the soft skills or soft interventions that help people with low back pain. But you bring up a good point. I think the textbook assumes that a patient will know their response to a specific test or question. For example, like in response to this movement, does the pain lateralize or centralize? The problem with the emergency care environment is a patient may come in like an hour after their pain started, and you may ask them like, if I do this, does the pain, shoot down your leg, or does it not shoot down your leg? They may not know the answer to that. They may be like,
it just hurts.
I don't know. It's been 30 minutes and
it
like,
hurts everywhere.
It hurts so bad. Yeah. And so I think the textbook assumes that, that everybody's going to fall into this yes or no response, but that's really not the case practically.
Yeah, but I do think that we do need support for what we do. Like it's very hard to say we go in there and we do some magical thing, which is what most of the attendings say. I don't know what they do. They go in there and they make things better and then they come back out. So it's nice to try and like at least standardize a little bit of an approach in this environment.
Yeah, definitely.
What is your experience, and you can speak to some of your research or just your personal experience about best ways for us to help educate patients about pain? Because as physical therapists, we're committed to helping combat the opioid epidemic, and particularly at the start of care, if patients really have like that acute pain, to help them avoid that trajectory. So what are some things that you have found, either research or anecdotally, that have been helpful for you?
Yeah, I think some of the benefits. So we basically just wrapped up a qualitative study where we interviewed some ED patients with low back pain, some of whom had seen a physical therapist and some of who didn't. And the manuscript's currently under review, but I'll share some of the themes we found from that. And I think one is sort of focusing on pain as being something that's very normal to experience, and also to sort of set the goalposts on the goal isn't to get your pain to a zero. The goal is to allow you to return to the meaningful activities in life despite the pain. So we want to reduce the pain enough such that it doesn't interfere with your ability to do the things you care about, like participate in social interactions, to perform your obligations to your family, to work, because those are the things that patients identify as sort of being one of the worst things about low back pain. It sort of takes away their identity. It takes away their participation in meaningful activities. And I think sort of resetting the goalpost to the goal isn't to get your pain to a zero. Like, I don't think we should ask patients, what's your pain anymore, from a scale to 0 to 10. I think it sort of sets the expectation that we need to get it to 0. I think it's more so like, we need to get you back to a place where this back pain doesn't control your life, and you can, return to the things that that are meaningful to you. I think also patients really appreciate sort of forecasting what the next couple of weeks will look like, and how the overall prognosis for back pain is generally favorable. Like, we find that 80% of patients, for example, this pain will go away on its own within a month or whatever. And so really the goal is just to get you in a place where we can get you doing the activities that you need to do despite this pain. And then in most people, it'll go away. I expect that tomorrow when you wake up, it's going to be worse. Or whenever you do this home exercise program, it's going to be a little worse. But in the long run, it's going to be better. So sort of forecasting to them what the next couple of weeks will look like. Because one of the things patients really identified that was helpful was, the physical therapist really provided me with a plan going forward. Like, this is what it should look like. If it doesn't get better by this point, you're going to see this person. this person may recommend this. And then if you're doing, if you've recovered by then you won't need that. And if you haven't recovered by then they may recommend like an MRI. So I think just knowing sort of what's going to happen after they leave the ED is really helpful for patients,
Yeah.
particularly because the time that the physician spends with the patient in the ED, at least from the patient's experience, is very like helter-skelter. They say like, oh, the patient or the physician came in for like 15 seconds and talked to me and then ran out because they had to go do something else. And they mentioned that, when I came in, I had this really severe, terrible pain. I didn't know what to do. Nobody really talked to me about what the test results meant or why I'm feeling this way.
Yeah.
And then they were like, you're not going to die. See you later. You're discharged.
Yeah, I think that's very common. But the way you talk about pain education, are you sure you're not secretly a physical therapist?
No. I mean, I think basically whenever I talk about technical components, I always have to text Kyle and be like, am I describing this correctly? Am I using the right word? Especially with this vestibular study we're doing, I would say my vestibular knowledge is very, very, very low. And I think it's interesting. Like whenever you research a topic, you always become more knowledgeable about the topic itself, even though
Mm-hmm.
you're supposed to be the quote unquote expert doing research on it. But it's been really a great way for me to learn more about vestibular stuff and the patient complaint of dizziness and vertigo. And the only reason we added on this dizziness vertigo study is because we already had the research framework in place for this back pain study. So it made sense to study also the second most common condition.
So how are you making a protocol for that?
It's sort of the same way, I think viewing it from like treatment-based classification, like we do low back pain, but maybe more like a diagnosis-based classification.
Mm.
So sorting into categories like BPPV or position or vestibular neuritis, and also having sort of like a catch-all category for undifferentiated dizziness. But it's basically the same thing. We protocolized like a formal document that the physical therapist uses specific features that the patient describes in their interview and responses to diagnostic tests and sorts them into a diagnosis category.
That's great.
Yeah, well, I'm excited to see what that shows. So we basically don't have any data that's been reported on it yet, but we have a vestibular therapist colleague who's working with Kyle and myself, who will be presenting, I think, a platform on that at APTA CSM in February, is it? So
Yeah.
hopefully we'll have some interesting data to share then.
Awesome. Well, just to change gears a little bit, one question that I often like to ask our physician partners in the emergency department is, how can we communicate better with you to help streamline the care that we're providing, not get in the way of something more emergent that might be going on? Like, what is the best way, like as consultants and part of your team, that we can really communicate most effectively?
Yeah, I think that just going in with the knowledge and being comforted by the fact that like the physicians almost universally appreciate having you. Like I would say emergency physicians kind of have a different culture than say other parts of the hospital. Our hierarchy is kind of very flat, where
For sure.
we work side by side with like every other staff member in the ED. So it's technicians, nurses, docs. We all work at the same workstations, and we have a very flat hierarchy. So for the most part, I think that emergency physicians are generally very approachable in terms of there's no like, why are you coming in here and challenging my diagnosis, or why are you recommending this because I just asked you to go do that. Of course, there are exceptions to every rule, but for the most part, I think we're really good about that. So I think just understanding that we want you there, we value you there. And in a lot of these areas, like the etiology of low back pain or differentiating different types of dizziness, we really want your expertise and your help. So just knowing that we really value your input, I think is a great place to start. The other aspect you touched upon is emergency physicians are also just incredibly busy. Typically, we see 20 to 25 patients a shift, and probably have like 12 to 14 simultaneously ongoing at once. In addition to that, following up on test results, taking calls, calling consultants, talking to family members, et cetera. So we'll always look busy. And that's not even mentioning just a random patient who may come in with a stroke or respiratory distress that needs intubation, or a gunshot wound or stabbing that we can't even predict when those will come in. So there's never a great time to come in and talk to us. So just knowing that, like, we're always approachable and we always value your advice, I think is a great starting point. And just knowing that, like, we would really appreciate you offering a suggestion on what could be causing this symptom and what we should do. And so I would say, don't be afraid to come in and say, you know, I saw this patient with dizziness. I think this is pretty clearly a case of vestibular neuritis. Here's why I recommend we do this. All the ER docs I know would love that.
Awesome. What should we do if there's a big disagreement? Like, I've had a couple of
Oh,
cases where I will say, hey, I really think this patient needs a CT scan. I'm concerned about maybe a tibial plateau fracture, just as an example. And usually I
uh,
don't have any kind of issue with the attendings or our APP partners, but sometimes it's more at that kind of learner level, that resident level where they're still learning. And what's a good way to like manage that when the response you get is no, like that's not appropriate? Like, how would you suggest like kind of conflict resolution?
yeah, that's an interesting question. I don't know that I could offer blanket advice for that because I
Sure.
think it would really just be um, situation specific. So it depends on how strongly you feel about that test. And you know, we all have you can burn a limited number of cards at your time at an institution, and you just have to
Yes.
decide, you know, I'm allowed to freak out once every 5 years and just like completely lose it and, you know, overturn a table and throw stuff. Do
Ooh.
Am I ready for that to be this time? So I think everybody gets one pass on sort of just being like, no, this has got to happen. I'm going over your head. So you just, maybe not one, but you have a limited number of times you can do that before you're sort of you know, known as the person that always does that. So I think you just have to decide, how strongly do I feel about this? What's the probability of it affecting patient care outcome? And sort of, am I willing to make a big show of it in this particular case? So it's really situation specific. I would say something like, I think this patient has a tibial plateau fracture. For me, would probably be not as big as something like, I think we could miss something serious like a stroke here, just because when they try to ambulate that patient with a tibial plateau fracture, it's not going to go well either, and it may
Right.
ultimately lead to them getting a CT because they may not be able to discharge them.
Hmm.
But I would say in general, like general conflict management techniques of disagreeing with someone is to say, oh, well, here are the reasons. Like, I can see where you're coming from. Here are the reasons why I think they need this, and you know, here's why I think we should consider this. Um, is just sort of general conflict management. And then, you know, there's always another person to talk to. And there's always a shift
Exactly.
change.
Yeah.
So
Well, I did have to do that once with a patient who I did
mm,
think was having a stroke. Like,
mm,
was not getting the headway that I needed at that time. And we
uh,
were very new in the department then, so I don't think we'd like kind of established that reliability and credibility that we have now. And at shift change, I was able to kind of get that moving in the right direction. But I think that's also part of why we have stroke alerts that anyone can call in
yeah.
case of a situation like that. And while it didn't change the overall management, I wish I had advocated better at that
Mm,
time. And I blame myself for that because I just wasn't quite prepared to like go to the ropes at that point because I was so used to that not flat hierarchy in other
yeah.
areas of the hospital where it's very like there's a very clear hierarchy and who's in charge. In Colorado, it's a little different because physical therapists can order imaging. So we feel a little more confident in our skills than perhaps some of our colleagues who are in states where that is not part of their practice act. But I think that's really good advice. Particularly, I want to contribute to our learners and our learning environment, particularly our residents, and help them see the value of physical therapy. So I think the best we can do to support them, I think, is another good way to help with that kind of conflict resolution. Like, let me help you understand my rationale here.
Mm. Yeah, and I think an important point is also in the ER specifically, we have a lot of off service rotators too.
Yeah.
So when I
Oh.
describe the ER
Mm,
cultures as being a really flat hierarchy, we may still have trainees from, you know, internal medicine, orthopedic surgery,
mm,
ophthalmology, psychiatry, whatever, rotating, who may not totally get the culture or even understand that they're physical therapists in the ED. Um,
yes.
But I would say the vast majority of physicians, like when you tell them, oh, hey, I did this and I'm really concerned about this, we should get this X-ray or CT, are just going to tell you yes. So this
I totally
it would
agree.
be a rare occurrence. If we were working together and you told me, when you started the sentence, hey, I really think we should, I would just tell you, I'm going to stop you right there. Let's just do it.
I love
Um,
that.
but in the same scenario, if we were working together and you had a problem, you really think somebody needed something, um, and you're having trouble convincing, somebody like a resident or intern, et cetera, to do it, I would I would totally welcome like a sidebar conversation. And most likely the way I would manage that is I would, most of the time go ahead and order what I think or what you think we should do, and then I would just have a side discussion with the resident.
I'm going to tell you the story because you're going to think that this is funny because Dr. Hurd.
Yeah.
So Dr. Hurd and I were working together, and I said, Dr. Hurd, I see that there's a hip CT ordered for this patient. And based on their chart review and talking to the patient, I don't think that's necessary. And I'd like to complete my exam before we do this imaging. And he just laughed and he looks at the resident and he goes, Dr. Griffith has some questions for you. And then he walked away and he left this poor resident. But we had this really good conversation. And the resident said to me, I thought we would do the imaging and then do a musculoskeletal exam. And I said, I'm going to encourage you to think about that differently. Let's do the musculoskeletal exam first and then see if we still need that imaging. And it turned into a really good learning moment for that resident and for me about we can save the imaging, we can look at things a little bit differently and leverage our distinct expertise in that situation. But I think you could probably imagine Dr. Hurd doing exactly that thing.
Yeah, I can picture it right now. Yeah.
And when you talk about off-service interns, I had a neurology resident the other day in the ED consulting on a patient, and he said, I need you to see this patient. I think they have BPPV. And I was just joking with him. And I said, buddy, I guarantee you they don't. and I said, and if they don't, you owe me a Diet Coke. And he said, well, they better, because when I was an intern in the ED, you're the one that taught me how to assess it. So if I'm wrong, then it's your fault and you owe me a Diet Coke. So I did go in there. He was totally right. I treated the patient. It worked out great. But it was really cool to have had that experience where I actually got to help teach one of the interns a skill that he was able to take forward to the next step of his career. So
yeah. And I think even having the conversation with whoever you're having the disagreement with, maybe there's something, that the physician is thinking or the trainee is thinking on their side that physical therapist isn't aware of, that you could find out too. Like it may be listen, the radiologist, the head radiologist that's on today is overcalling everything. He's thinks everything is a subdural, he thinks everything is a tumor. So let's not get the head CT on this one. It's very low risk. The patient has a PCP appointment scheduled for tomorrow. Let's let him go to that and get so there may be something else. Listen, the radiologist is overcalling everything today. Let's not do it if we think it's low likelihood.
I think you raise a good point too, in that I always try to tell people when they're working in the emergency department, you need to speak to the provider. You can't rely on what's in the chart, because you may have so much information in your head that may not make it to the chart until the patient's gone. And so I always tell people, please make sure you're speaking to the physician or the nurse practitioner or the PA, because they know what's happening, and the nurse. Don't just read the chart and go do the thing, because you may be missing key information. So I think that's a great example of that.
Yeah.
All right. I think it's time for the case. Do you have a case you want to share where you had to involve physical therapy and everything turned out great or terrible, however the case may be?
I mean, I have a lot of cases. I think that, there are a couple of distinct ones that stand out in my mind. I think, there are cases of patients who come in who we would otherwise hospitalize because they have this condition or they need to be evaluated for placement, et cetera. And one patient I have in mind that Kyle and I saw together was a patient that came in and had two orthopedic injuries at once, an ankle injury and a wrist injury. And the ankle injury ended up, I forgot what it was exactly. Maybe it was a knee, but it needed to be non-weight bearing. So she needed, crutches or a little wheelie walker thing, but also had a distal radius fracture or something like that, where she couldn't really use crutches. So normally that's a double orthopedic injury that we would think you would need to be admitted to the hospital for some sort of specialized placement. But we were able to, get our physical therapist down, to get our social worker down, and basically arrange for the patient to just go directly to an assisted living facility from the ED instead of being hospitalized. So that's a great example of sort of resource utilization to save a hospitalization. I think especially now in this era of hospital care, ED care, our two most precious resources are hospital beds and staff. And everywhere is facing a hospital bed shortage with long boarding times. So if we can remove unnecessary hospitalizations, that helps in that regard. And then there are other great examples of somebody getting immediately better, like with dizziness, vertigo. You come in and they had this big workup scheduled for like, oh, we were going to get CTAs of the head and neck, and then we were going to keep the patient for MRI. But Kyle went in and this he said this patient's a slam dunk for BPPV and did an epley, and they said they're completely better now and they can go home. There are sort of countless cases like that. For back pain, that's a little harder because there's not a maneuver we can do that just sort of makes a patient instantly better in the ED. But it can really take a patient from like your gut reaction when they come in is no way this guy's getting out of here. He's going to need to stay in the hospital because he's in bed, can't move, got wheeled in a wheelchair, has so much pain, is reporting 10 out of 10. But really there were other factors at play. Like they had a lot of fears about whether this was going to be like a permanent disability because their uncle had back pain, got spinal surgery, ended up paralyzed, et cetera, whatever. There's some horror story that they've heard in the past and they were really worried about that. And they went from like you thinking, oh, this patient's never going to be able to go home, to like, they're really happy and they're like, I'm really glad that we didn't find anything serious. And, they said this is like a classic presentation for sciatica. And this is, we're giving you this medication that, should make you feel better. If not, we'll have you follow up with this type of doctor. You may need an MRI. And they're just really happy that they have a plan to deal with this going home. So those are just some examples of cases in which having an ED physical therapist has been really valuable.
I love that. I had a case kind of similar yesterday in a patient who came in from a long-term care facility, and her husband was very concerned because she hadn't walked in months. He said she can't walk. When she went in, she could walk. Now she can't walk. It turns out it was really more of a cognitive issue than a physical issue. And she just needed kind of the right cueing and support and the right adaptations to where her mind was to really help her be able to function. But by being a person who was comfortable working through that with them, I was able to get that patient up and walking up and down the hallway. I think she walked like 500 feet, and he just couldn't believe that she could walk. He thought she was never going to walk again. And they had just been keeping her in a wheelchair because of her cognitive issues. So my hope is that like the trajectory will totally change for that patient.
Yeah, that's awesome. Yeah, and sort of a similar type of case, but I'm now that we've had as part of this trial that we're conducting in low back pain, we're supporting like more physical therapist efforts so that they could be physically present in the ED during the day and not be pulled to other areas of the hospital to see like inpatient consults, for example. And so as a result, we have more physical presence in the ED. And I'm just keeping a running list of things that our physical therapists are just picking up, things that don't even relate to low back pain or dizziness or vertigo, just by virtue of having them there. So the example I'm thinking of is there's an elderly patient who was altered, wasn't really able to communicate well, but hadn't gotten out of bed in like 2 or 3 days, and nobody really knew why. And the team had sort of planned to admit them to the hospital for a full workup, evaluation for placement, for PTOT to see them as an inpatient. And Kyle was sort of like, well, I'll just go in there and see if I can figure out what's going on. And he's like, so I went in and I worked with her and I arranged every joint, and turns out like she cannot move her left hip. Let's get an x-ray. And turned out she just had like a hip fracture, and that's why she hasn't been getting out of bed. And she's altered because she hasn't slept, she's not eating, she's in so much pain. And so really isolating a specific cause of sort of a more vague general condition.
Total win. Awesome. Well, thank you so much for being with us today. Do you have any like final parting thoughts for physical therapists in the emergency department?
No, I mean, I think it's a great resource. Obviously the physical therapists we've worked with have really enjoyed working in this environment, and I know the clinicians love it, the patients love it too. I think that it's a really good area for hospitals that don't have this to really invest in.
Mhm.
I don't know that we're going to be able to prove some like really impressive whopping number, like you save $14 million a year or something by having an
Yeah.
ED physical therapist. But I think it is, we can demonstrate that it's a self-sustaining position in terms of like number of consults you generate.
Mhm.
It may not be something that saves a crashing hospital budget, but it certainly can be self-sustaining. Patients really love it. Clinicians love it. It helps. It helps a lot of the. I think it also helps, I should say, a lot of the unmeasurable things too, like morale of the department, morale of
Uh-huh.
patients, throughput, stuff like that, that you can't exactly measure like on the bottom line, but really improves, the patient experience, the physician experience, the nurse experience of working in what is a very difficult environment.
Especially right now.
Mhm.
Okay, well, thank you so much. And thank you for tuning into our last episode of this season of the podcast, Admit It or Not. We would encourage you to like and subscribe, and you can find more resources on how to start an ED PT program on our website. Thank you so much.